Geriatric medicine is practiced by many different clinicians in wide variety of settings: hospital wards, outpatient clinic, day hospital, general practitioner, surgeries, and home, the patient own home. Most doctors will spend a large part of their time dealing with older patients, which is why geriatric medicine is important. It's also a challenge. Illness in older people often present in atypical ways, and there is sometimes an inaccurate perception that little can be done to help them, or that their problems are social rather than medical. Age-related difference. There are important differences in the physiological and presentation in older people that every clinician needs to know about. These terms affect assessment, investigation, and management. Special feature of illness in older patients is different. Multiple pathology is characteristic. Older people commonly present with more than one problem, usually with a number of causes. Young person with fever, anemia, heart murmur, and macroscopic hematuria may have endocarditis, but in older person, this presentation is more likely to be due to urinary tract infection. Aspirin-induced gastritis and aortic sclerosis never stop at single unifying diagnosis. Atypical presentation. Older people commonly present with general deterioration or functional decline, acute disease, often masked but precipitated. Atypical presentation. An 85-year-old lady was recovering from surgery on orthopedic. She became withdrawn and stopped eating and drinking. Before this, she had been well and mobilizing. Her temperature, pulse, blood pressure, and routine blood were normal. Her heirs thought her carer thought she was acting as if she wanted to die. However, it was later noted that her respiratory rate was high. X-ray showed pneumonia, and she is treated and be very well. Older people with serious medical problems don't present in textbook fashion, but with fall, confusion, immobility, incontinence, yet are perceived as failure to cope. Old age medicine is complex, and a failure to attempt to assess people problem as medical are unacceptable. Deficiencies in medical care can lead to failure to make a diagnosis, improper and inadequate treatment. Old age medicine is complex, and failure to attempt to assess people problem as medical are unacceptable. Deficiencies in medical care can lead to failure to make a diagnosis, improper and poor performance. Some clinical findings are not necessarily pathological. Neck stiffness, positive urine dipstick in women, mild crackles at the base of the lung, slight reduced PaO2, and reduced skin trigger may be normal finding in older people. Reduced hemostatic reserve. Aging is associated with a decline in organ function with a reduced ability to compensate. The ability to increase heart rate and cardiac output in critical illness is reduced. Renal failure due to medications or illness is more likely. Salt and water homeostasis is impaired, so electrolyte imbalance are common. Impaired immunity. Older people don't necessarily have a raised white blood count or fever with infection. Hypothermia may occur in a state. A rigid abdomen is uncommon in older people with peritonitis. They are more likely to get generally tender but soft abdomen. Measure the serum C-reactive protein can be useful when screening for infection in an older person. Some Clinical findings are not necessarily pathological: neck stiffness, positive urine dipstick in women, mild trickle at the base of the lung, slightly reduced PaO2, and reduced skin trigger may be normal finding in older people and don't always indicate disease. The importance of functional assessment and rehabilitation in older people may take longer to recover from illness, pneumonia, compared with younger people. However, their ability to perform activities of daily living and thus again independence can improve dramatically if they are given time and rehabilitation. In 1930, the very first geriatrician realized that thousands of patients living in the hospitals and workhouses were not suffering from old age, but from diseases that could be treated: immobility, falls, incontinence, and confusion, called the geriatric giants, because they are the common presentation of the different illness in older people. The geriatric giants, the four, were originally coined by Bernard Isaac, professor of geriatric medicine: incontinence, immobility, instability, fall, and syncope, infection. Bernard Isaac, professor of geriatric medicine: these giant: incontinence, immobility, instability, falls, and syncope, and intellectual impairment, delirium, and dementia. Several different illnesses can be present as one of the geriatric giants. Two common examples also begin with the letter I: iatrogenic disease caused by medication and infection. The common source of sepsis in older people are the chest, the urine, and the biliary tract. Simple intervention can make a big difference. Another characteristic of geriatric medicine is that simple intervention can make a big difference to patient function and the quality of life. Ear searing, cataract surgery, and a new pair of glasses can dramatically improve person's sense of social isolation and loneliness. Specially fitted shoes, a properly measured walking aid can improve balance and mobility and confidence. Reduced medication can stop a person from feeling dizzy when they walk and allow them to go out of the house again and improve their quality of life. Adaptation at home can allow people to function more easily and retain their independence. Activities of daily living, mobility, including aids and appliances, washing and dressing, continence, eating, drinking, shopping, cooking, cleaning. This is the daily activity. Can assess how the quality of life of the older patient when older people have the benefit of medical assessment and the treatment for problems which are often perceived as being due to old age, incontinence, fall, memory problem. They and their carer can enjoy better quality of life. Comprehensive geriatric assessment is assessment of the patient made by the team, which include geriatrician, followed by intervention and goal setting. Agree with the patient and carers. This can take place in the community in the assessment areas. It covers the following areas: medical diagnosis, review the medicine and concordance with drug therapy, social circumstances, assessment of cognitive function, functional ability, the ability to perform activity of daily living, environment, economic circumstances. Randomized control trial show that comprehensive geriatric assessment lead to improved function and quality of life and also reduce hospital stay, readmission rate, and institutionalization. There is no evidence for the effectiveness of a comprehensive assessment that doesn't include a doctor trained in geriatric medicine. Communication in geriatric medicine. Communication is particularly important in geriatric medicine. A history from the patient, relative, or carer is often required and may be different from that of the patient. The assessment of older people often require a multidisciplinary team, and the observation skills and opinion of nurses, physiotherapists, occupational therapists, and social worker may shed significant new light on the patient problem. Doctors who work with older people need to be comfortable with this multidisciplinary approach and often puzzle-like progress in the assessment that can sometimes occur. Communication with older patients may be difficult because of impaired vision, deafness, dysphagia, or dementia. Healthcare professionals can aid communication by checking that the patient can hear what being said, writing down instructions, and involving the carer with the consultation. Communicating with older patients may be difficult because impaired vision, deafness, dysphagia, and dementia. Healthcare professionals can aid communicating by checking that the patient can hear what is being said, writing down the instructions. He can read it, involving care in the consultation and decision making.